Good morning, good afternoon, everyone. Welcome to today's DCB Academy session. It's both an absolute honor and pleasure to have Dr. Grasso with us today. He is a renowned expert and key opinion leader in this field. Today, he'll be sharing his valuable insights on mitral regurgitation and transcatheter intervention. Thank you very much for joining us here today, Dr. Grasso. Please.
Thank you, Sarah, for the presentation. Thank you to everybody for connecting for this lesson. I will try to give you an overview on mitral regurgitation and what to do when we talk about transcatheter mitral intervention. So we start from the beginning. I don't want to teach you which is the difference between primary and secondary MR, but we know that there are two different entities. Primary MR is something directly due to the abnormality of the valve. And so the lesion and the mechanism is due to a malfunction of leaflet at the valve. It may be degenerative, rheumatic, or due to endocarditis. And LV dysfunction is a consequence of mitral regurgitation. Secondary MR, instead, we have the valve structure is normal, but the mitral regurgitation comes depending from different mechanism. We know that for many years, we talk about secondary MR due to LV dysfunction, LV remodeling, and it may be due to ischemic heart disease and cardiomyopathy. But we now know that we have another type of functional mitral regurgitation that is atrial functional mitral regurgitation. And this is due to an enlargement of left atrium with a consequence of mitral annular dilation in patients with long-standing atrial fibrillation, in which LVF is normal. In the figure, you can see the comparison between secondary mitral regurgitation due to left ventricle dysfunction and atrial functional mitral regurgitation. So these are two different entities with completely different outcomes. And as you can see, the atrial functional mitral regurgitation is due to a deviation of the posterior annulus with the posterior leaflet chattering and enlargement of the annulus that causes the mitral regurgitation. So, of course, you know that the gold standard for treating mitral regurgitation is the surgery. You know, the surgeon is able to do every kind of repair. He can cut the leaflet, he can put a ring to reduce annular dimension, he can implant a new cord, can close cleft, he can do many things. Or in case of the valve is not treatable for repair, he can put a valve. It may be mechanical or biological valve. But still we know that surgery can treat all the patients, and it is mainly due to the comorbidity and the high risk of patient. So as interventionalists, we very often copy what the surgeon do, and this is the case even for mitral valve. So there were many devices that comes to treat the mitral regurgitation. First of all, mitral repair with the edge-to-edge techniques. And you know that we have two different devices, this MitraClip from Abbott and Pascal from Edwards Life Science. We have different devices to do annuloplasty, and we're dealing even with replacement with valve. Today we will talk to you about mitral TEER, mitral transcatheter edge-to-edge repair, since we have not so much working devices on annuloplasty, and we still have just the tendine for replacement of the mitral valve. It will come the Edwards 3, so we are waiting for this new improvement, but we still have many problems to solve. So the established therapy is just the edge-to-edge therapy, And today we will talk about this. When we start to deal with the mitral regurgitation, with the transcatheter repair, it was very, very long time ago. You know that in 2011, the Everest 2 trial was published, and it came to us with incredible results. And the results say that mitral repair was safe and effective if compared with surgery in degenerative. The majority of patients were degenerative mitral patients. Since that time, many patients were treated, but as you can see, there was a noisy silence of mitral clip trials. So everybody start to put mitral clip on all the valve, and the majority of patients in the real world were functional mitral regurgitation. And then we start to publish many registry in the US, in Europe, in Italy. We do a really lot of patients. And then we understood the patient as a quite good result. We know that when treat the patient, when we solve mitral regurgitation, the patient, because it feels better. And so we were encouraged about this, but still guidelines doesn't change it, because you know that we need much more robust data that comes only from randomized controlled trial. So in 2018, MITRA-FR and COAPT comes. And then we have the first result. It comes with MITRA-FR trial. And as you know, we have no results from this trial. This trial concludes that the mitral clip plus optimal medical therapy, when compared with medical therapy alone, has no difference. So it means that mitral clip doesn't work. So why to continue to treat this patient? Few months later, the COAPT trial was presented by Greg Stone, and it was an incredible result. As you can see, mitral clip showed reduction of hospitalization for a failure, but still a better outcome in terms of death from any causes. So we have these two similar trials. We did all with mitral clip versus optimal medical therapy, but completely different result. Then when we went deeper into the trial, we saw that we were treating completely different patient. MITRA-FR patient was patient very diseased with big ventricle and less mitral regurgitation if compared with COAPT patients, in which we have patients with smaller ventricle and a prominent and severe MI. Even the experience of the center and the result of the procedure were different, but we will not deep into this study. So what we understood from these two trials is that the important things to treat the mitral regurgitation patients is the timing. So COAPT patients are patients that are treated earlier, before the ventricle remodeling of the ventricle is too severe and the ventricle were too dilated if compared with MITRA-FR. So if we wait to treat patient and to wait that the patient it's a MITRA-FR patient, you will get no results in terms of survival. And that's easy to understand, because of course, if you have very diseased ventricle, the things that drives the result of this patient is due to LV dysfunction, and the mitral regurgitation with its treatment has lower impact. So, who is the ideal patient to be treated with transcatheter intervention? The best patient is a COAPT-like patient. COAPT-like means that we have to do all these three following criteria. So absence of severe left ventricular impairment, absence of right ventricular impairment and or severe pulmonary hypertension, and absence of hemodynamic instability. If you treat patients like this, you will get the result even in terms of survival. This two trial led to a change of the guidelines, both Americans and European guidelines. And I will show you a comparison between the two guidelines. There is some slight difference, but all the guidelines are concordant in terms of recommendation and indication. So we have to treat, when we deal with primary MI patients, we have to treat all symptomatic patients. If we have no symptomatic patients, we have to treat patients that are starting to have an impairment of left ventricle. So we have to treat patients with the ejection fraction less than 60% or initial dilation of left ventricle. And this is the same for both American and European guidelines. But in Europe, we treat in patients that start to have enlargement of left atrium or increasing in pulmonary artery pressure. In the American guidelines instead, you have to treat patients in which the repair, the transcatheter repair, not transcatheter, just the repair, has a likelihood of durable repair and expected mortality rate very low. That means less than 1%. TEER has an indication 2A in the American guidelines, 2B in the European guidelines, and it is reserved to patients with high or prohibitive surgical risk, and of course, no futility is to avoid. When we deal with secondary MR, we have something different. Because in European guidelines, we do the indication in case of other intervention, maybe for CAG on the other valve disease, and we have indication 1B, and it's a little bit different in United States, in which the indication, the recommendation is 2A. The TEER has a level of recommendation 2A in both American and European guidelines, in which when we have patients with symptoms despite optimal medical therapy and are not eligible for surgery, and the criteria is just that you have success with TEER repair, with TEER transcatheter repair. In the American guidelines is a little bit different, but I would say this still the same. We have to be sure that you have the right anatomy and that your repair will be successful. Here we have another summary of the guidelines, comparison between the two, but still you have to treat in the primary mitral regurgitation, symptomatic patient without LV dysfunction, and TEER is just recommended for patients with LV dysfunction. If you are a patient with no symptom, the indication is for surgery, of course. In case of LV dysfunction or high-risk surgery, you have to do, you can do even repair by transcatheter techniques. In the secondary MR, instead, the situation is a little bit different. So if you have patient that goes to cardiac surgery for any other reason, you can do the correction with during the same intervention. The opposite, if you have in Europe, if you have for high risk patient ineligible for surgery, we can do with an indication 2A, we can do transcatheter repair. If you have isolated mitral regurgitation, symptomatics despite good medical therapy, in case of low risk, it is indicated mitral valve surgery. In case of high risk patient, the indication is 2A in both the guidelines. So at the end of the day, which patient we have to treat. So the summary is that if you have a severe MR not eligible for surgery and TEER is suitable for anatomical characteristics, you have to treat COAPT-like patients and the indication is for outcomes, as we have the result of the COAPT, but still you can treat even mitral FR patient and the indication is for the symptoms and the quality of life. So it is important what to expect and what to say to the patient when we treat them. So we have spoken about anatomical suitability for TEER. Since the beginning, we understood that small valve area, very diseased or rheumatic valve were not ideal for treatment with H2H transcatheter repair. And here you have a summary of mitral valve characteristic that says that a TEER is non-complex and ideal for TEER, or it is a very complex valve that it is ideal if it is made in a very high volume center, but of course it is not a startup case to deal with. When you go toward the right place of the graph, probably the best option is to replace the valve instead to repair it. But still, we have to come with the replacement device. So maybe it will be the time in few months. So which are the devices that we have for the transcatheter H2H repair? We have the mitral clip. We are now with the G4 generation 4, and it comes in 4 sides. We have the shorter one and the longest one that is called respectively NT and XT, and both the lengths comes with a wider clip that is called with a W on the name. So we have the NT wide and the XT wide. Instead, Edwards, that comes later, as you know, had the Pascal devices. The first device was the Pascal P10. That is the device on the right. It was the device with the spacer inside, with a large paddle, and it comes with a completely different technology, because the mitral clip has a sort of active. It is called an active device because we close and we force the closure actively to grasp the leaflet. Instead, the Pascal device has a nitinol construction, so it has memory of its shape. And when we close the Pascal, it is the nitinol that causes the closure of the Pascal device. So it is a little bit more elastic than the clip device. Then after the P10, it was the first version, larger with the spacer inside. Edwards comes with a smaller device that is the Pascal Ace, and it comes without spacer in the center of the device and with a smaller clasp. So all this device are used in different setting, and in different anatomies. So I don't want to bother you with the study that you probably already know. So I will do very fast through the majority of the study that we have. And here we have the result of the COAPT trial at 5 years. And you may see that still we have reduction of death from causes and hospitalization in the group treated with the mitral clip. And the results are sustained at 5 years. These are the results from the EXPAND study. It was all the patients were treated with the third generation of the mitral clips with the XTR NTR clip. So it was an older version, but still we have good results in terms of reduction in mitral regurgitation and improvement in NIA class quality of life and functional capacity. This was the European registry. It was called EXPAND G4. because the patients were treated with generation 4 of the MitraClip, and these are the results at 1 year. As you can see, the improvement in terms of mitral reduction and near functional class, and even the reduction of hospitalization are significant if you compare the baseline with the 1 year result. This is the CLASP registry. It was the first registry made with the Pascal system, in which we have functional mitral regurgitation patient and degenerative mitral regurgitation patient. And it demonstrates less hospitalization for congestive heart failure, and a decrease in mortality at 2 years of follow-up. And it was comparable results with the COAPT trial. This is instead the CLASP 2D trial. It was made by Edwards, and it is a direct comparison between Pascal and MitraClip in degenerative mitral regurgitation. It randomized to 180 patients, and you can see even at the result of 1 year that the Pascal system is non-inferior to the MitraClip system for DMR. It provides significant reduction, durable reduction of mitral regurgitation, and of course improvement in terms of quality of life in both devices. So we may say that Pascal is comparable to MitraClip, and it is used maybe sometimes different setting, but still we have not so much data to say where it is better to use Pascal, where it is better to use MitraClip. Someone is starting to do some provocation and to do, okay, yeah, it is better to have a Pascal, yes, MitraClip, but in my opinion, I treated almost 900 patients. Still, I don't know where to use one or the other device. So we have even other trials that are coming, the RESHAPE F2, I will show the results in a few moments, that deal still with the MitraClip versus optimal medical therapy patients. And it is a sort of patient in between COAPT and MitraFR study. The repair that we compare MitraClip versus surgery in severe degenerative MR in patients with moderate surgical risk, and the CLASP 2D 2F, in which there will be a comparison between Pascal and MitraClip, both in patients with degenerative and functional mitral regurgitation. These are the RESHAPE F2 trial that compared TEER versus medical therapy. And as you can see, the primary endpoint shows better results in terms of heart failure, hospitalization the reduction, and cardiovascular death if compared with the control of medical therapy alone. A majority of the events were driven by reduction of heart failure hospitalization. And of course, MitraClip improved quality of life, as we have seen in all the study, the registry made with Transcatheter TEER technique. These are the results of the Matterhorn trial that sealed with surgery with secondary mitral regurgitation. So there were no difference. It was non-inferior to surgery in terms of composite endpoint of death, heart failure hospitalization, mitral reintervention, or assist device implantation and stroke at 1 year. But MitraClip TEER, I would say, has, of course, a better safety profile when we deal with composite endpoint that include death, major bleeding, and reintervention and new onset of atrial fibrillation at 30 days. So very promising result, but still we have and we need much trials and bigger trial to, I would say, to put the milestone on the therapy. So now I will show you a step-by-step procedure. So what do you do when you deal with TEER intervention? So first of all, setting of the cath lab. as you can see in the structural intervention, there are many operators inside. Usually at the table, we have first operator and second operator that helps you to maneuver the device. Even the anesthesiologist, you see, it is somewhere at the head of patient, of course, because we did the patient with the transesophageal echo, of course, in general anesthesia. The echocardiographer, I used to put the echocardiographer on my left side. So as you can see, it can see the angio screen. And this is important both for communication, because we are really near, and even because the echocardiographer could see the screen, the angio screen, and understand where we are, what we are doing. So there is a better connection. So we have many fellows in training, and these two guys, this is Dr. Tizzani, that I think you know very well. They're in Cleveland. This was Guilherme, and this was our best friend, Yohei Turiono, that in that years we have the privilege to have in Catania to work and publish many papers with them. So first step of the procedure, of course, is the transeptal puncture. Transeptal puncture, in my opinion, it is a very safe procedure if it is done with echo guidance, of course. And we have to do the puncture in a precise point of the fossa ovale. We have different view that we have to do with echo. The first view is the bicaval view. You can see we have here superior vena cava. I'm retracting the needle. I'm coming down from the superior vena cava to the fossa that is here. And in a few moments, you will see even the cuts that is pointing here toward the septal wall. And then we drop into the fossa. So once you reach the fossa, we have to see it in a superior position. We move in a short axis view. In a short axis view, it's very simple to recognize the structure. If we had the aorta, and then we say that we are anterior if we are near to the aorta. But in this procedure, we have to do a posterior puncture. So we move clockwise to go posterior with the needle, and then to move toward the posterior portion of the fossa. Then at this time we change view. We have a 4-chamber view in which we I don't know if you can see the video moving. Okay, I start again. Okay, here we have the 4-chamber view in which we have to measure the height above the mitral valve. At the beginning of the procedure, we have to be 3.5 centimeter for functional and a little bit higher for degenerative mitral regurgitation. But with the new device, nowadays we do the puncture at 4.5, 5 centimeter, because new device have much more excursion, so it is not difficulty to reach the dip of the ventricle just below the leaflet. When you are ready, you do the puncture, so you push the needle and advance the cut in the left atrium. And then at the end, I always do an angio in the upper left pulmonary vein, and I put a super stiff wire that will help us to bring our guiding catheter. So now we'll use the slide of my best friend, Federico De Marco, to show you procedural step with the two different devices, with the Pascal system and with the Masterclass. As you can see, once you put the guide wire in the pulmonary vein, upper pulmonary vein, you advance all the system in through the septum, and here you see the catheter goes in. Then you advance. In this case, this is the mitral clip. You have to advance the mitral clip in the left atrium, and you have to do what we call the straddling. So we have to put these two small markers and we have to push it to reach the end of the catheter. That is, here you can see the tip. This will give us the proper movement of the device when you have to steer towards the mitral valve. If you will see, we are pointing toward the upper left pulmonary vein that give us more room and more space to go out with all the devices. Of course, you can see handbrake on, just do with both hands that just to avoid to go suddenly into the left atrium to avoid any damage. Sorry. So this is instead the advancement of the Pascal device that comes elongated. So once we are out from the catheter, we close the device in the original position, and we have to do a maneuver. We have to be aligned and parallel, as you can see here at the echo, to the mitral valve plane. So it's a check that we do by applying flexing and unflexing in the guiding catheter to check that we are in 3D, we are parallel to the mitral valve. Sometimes this maneuver, it's not so easy to find the right view at the echo. So I perform an angio alignment that is much more quick, and it's really very, very reliable. So if you put your tube a little bit with raw orientation, we are perpendicular to the mitral valve plane that is indicated here in green. Then when we apply flex and flex to the catheter, you can see that we are flexing the catheter and we are parallel to the mitral valve plane. So this is a faster maneuver and much easier to do, and you can use even this if you want. So with the Pascal, we apply flex to steer the device toward the mitral valve. So we have to point with the tip of our device toward the apex of the ventricle, and even the angel, of course, help us. A little bit difference is with the mitral clip. So after we straddle that clip, so after we put the two markers in between of the tip of the catheter, we apply M knob here in the mitral clip device by having some more room by applying some posterior to gain some height. And even here you can see we are pointing towards the apex of the ventricle. It is very important to follow this maneuver in the X-plane view, so you can see in the two chambers, in the LVOT chambers, where you are with your device. So once we are toward the mitral valve, we have to check some few things. So first of all, we have to put our device just above the jet that we have to treat. We check both the trajectory here in the two chambers view and in the LVOT view. The LVOT, we have anterior leaflet, it is the leaflet near to the aorta, and the posterior leaflet, it is the opposite. In a two-chamber view, we are lateral when we go here, and this is LAA, and we are medial if we are on the opposite as on the right side of the screen. We can change the medial and lateral position by applying some flex to the catheter, or by going in or out with all the system. It depends on the trajectory that we have. The trajectory means that when we go up and down with the device, both with the Pascal and with the mitral clip, we have to go straight and perpendicular, both in two chambers view and in LVOT view. This is very important to have a very easy and effective procedure. Another alignment that we have to do is the orientation and clocking. When we do the clocking, it means that we have to be perpendicular to the commissure, to the coaptation line. You know very well that, of course, the coaptation line, it is not linear. It is some semilunar. It seems a smile. So if you go lateral, you have to clock your clip, your device a little bit clockwise to turn 1 o'clock and 7 o'clock to be perpendicular to this line. If you are on the center, so when you deal with a 2P2 lesion, you should have your device at 12 o'clock. When you are medial, you have to point your device between 11 and 5 o'clock to follow the coaptation line of the mitral valve. So these are the different systems. We have 3 catheters with the Pascal system, and the smart handle, and the steerable guide catheter with a mitral clip, but it's just a technical consideration and different way to use it. So when you are aligned and you are perpendicular, you have to cross the mitral valve. When you cross the mitral valve, you have to be sure to have the explain. So you have to check the pattern, the 2 chambers view, to go just straight by not pointing lateral or medial, and just to go just below the mitral, the free edge of the mitral leaflet. So not to go too deep into the ventricle, because we don't need it. The important thing is to check both at the echo and with the angio the orientation of the device, because sometimes when you go inside the ventricle, and so this release the tension of the system, you may have some rotation of the device. So you have to check it to control this rotation. Once we are into the ventricle, you have to prepare for the grasping or for the clasping, as if you are using the clip or the Pascal device. That means that you have to be just below the mitral leaflet. You have to be oriented, and then you have to start to pull toward the left atrium the device. As you can see, you have to see that both the leaflets are very well accommodated on the arms of the clip of the system. Once you have this image, and you can see that the leaflet is, the tip of the leaflet are just deep into the device, this is a good position. So you see that the leaflet are moving less, and they are still deep inside the device. And then you can start to do the grasping procedure. The grasping procedure means that you pull down the grasp, that are the atrial system that blocks the capture the leaflet from the atrial portion, and then you start to close the clip or the Pascal system to catch both the leaflet and then to check the result hereafter. One important thing is not to go too high with your clip. So you can see in the animation, okay, start again, that this is not a good position. When you close, you are just above the mitral valve plane, and this is no good because you have a lot of tension on your leaflet. As you can see in the right panel, this is the correct grasping technique, in which you have the leaflets without any stress, without any tension, and we are below the mitral annulus, mitral valve plane. So of course, when you do the grasping, then you have to check leaflet insertion. So we have to be sure that leaflets are well inserted, and so that we can release the device. You have to check in LVOT that the leaflets are well inserted. The tip are deep inside the base of the V given by the devices. On the 2 chambers view, you have to check that both medial and lateral side of the clip, the leaflets enters at the same level, and the segments are stable both medial and lateral to the clip. And you can verify the orientation of the clip. When you do end phase 3D reconstruction, you can see still the orientation. You can check again the orientation of the clip and the formation of the double orifice that is typical, of course, of the edge-to-edge technique. Before the deployment, you have to check all the hemodynamics. So you have to check, of course, mitral regurgitation. We have to check mitral gradient. You can check even the pulmonary flow that should be changed if you do an effective grasping. If you are not happy with the results, you can open your device and optimize the device position. In this particular case, we had 5 millimeters of mid gradient across the mitral valve, and then we rotate a little bit the second device, and we put it near to the first one. And after orienting and improving the position of this second device, we have a mid gradient of 2 millimeters of mercury. So it is important before to release a device to check all these things. And of course, you can see after the deployment, you very well see this nice 3D reconstruction. So these are some suggestions where you deal with the degenerative mitral regurgitation that is that gives us better results, because left ventricle is much more competent, but it is a little bit more tricky to treat. So as a general rules, of course, then you have to choose case by case when you have your valve to treat. When you deal with the prolapse, the concept is that you have to grasp the prolapse. So the target is the prolapse that is, in this case, is here in this valve. The second statement, to put a second clip to stabilize the first one, was true with the first generation of the mitral clip, when we have now the wider version. With the recent version, with the G4 generation, if we are able to catch all the prolapse with one clip, we didn't put no more a second clip. So this is the treatment of this particular patient with the prolapse and the flail of P2. You can see clearly the flail and the prolapse of this valve. And we go just in the target lesion was the prolapse, and then you can see here the grasping, the moment of the grasping of the valve. You can see even the result if you compare this 3D with the above image. You cannot see the prolapse coming toward the left atrium. When you have a flail, that means that you have some ruptured cord, like in this case. Then I will show you the moving image. The grasping is the ruptured cord. When you have the flail, you have to respect the orientation of the flail. So you have not to deal so much with the coaxial lesion line, but you have to align your clip with the axis, I would say, of the flail. This was a case you can clearly see the cord that in systole comes into the atrium. You can see the cord, even if among all the huge mitral regurgitation. In this case, there was, I think, a case of 2014 or 16. So we have just a smaller clip, and we have not the widest version. We were not able to do the grasping directly of the flail. And at that time, we use the zip technique. That means that we put the first clip near to the flail, just to have much more approximation of the leaflet, and then it comes much more easy to put a second and a third clip. And here below, you can see the result after the implantation of 3 clips. these are some tip and tricks from ancient time, I would say. Barlow disease. So Barlow disease should be avoided. Barlow disease is something much more complex to treat, and I think that the surgeon may do the best job, probably even by changing the valve. But sometimes you have to deal even with this kind of patient, and very often you have to put more than one clips to have the better result. In this case, you see a severe disease, severe Barlow disease with a huge regurgitation with multiple jets, and then we put 4 different clips. You can, I don't know if you can see here, 1, 2, 3, 4 clips. These are usually patients with huge and very large valves. So we have not so much issue about mitral valve gradient. Okay. Cleft. Okay, the cleft is some mythological entity because the real cleft is not so a common finding. What we usually see is the natural indentation of the posterior leaflet that in the diseased valve tends to be opened by the tethering of the leaflet. So many people calls them cleft, but these are not real cleft. By the way, if you find a cleft to treat and you have to deal with it, there are some tip and tricks. As in this case, you can see here the cleft of this patient. Okay, here other reconstruction. This is the view from the ventricle. The techniques is to put 2 clips just near to the cleft, one on the left side and one on the lateral side, and one on the medial side of the valve, by orienting a little bit the clip one towards the other. And this is a case made by Paolo Denti, and I show it by Cortes of him. So now I will show few cases. If you have question, don't worry to interrupt me. If you want to